Here is your question. All right, so if you have read and understood, considering it critical care scenario, please tell me, how would you manage this patient now?
According to the stream, my diagnosis is either pneumothorax or hemothorax.
Okay.
So to manage the patient according to the CCRISP protocol, so I'll
Yes.
check if he can talk or not.
Yes.
Then we have to look for breathing. As he's already having shortness of breath, we have to count the respiratory rate, how is the chest tightness. Then we have to do an urgent chest X-ray. Then
Yes.
we can either do a needle thoracostomy or maybe a intercostal chest tube drain,
Yes.
if it's readily available. Then we have to look for other signs for circulation. We can open white bore cannula and start crystalloid fluid. We have to check capillary refill, mental status, then blood pressure, pulse. So we have to start fluid challenge as well.
Okay. Can you please tell me, right, what are the different types of pneumothorax you are aware of?
So it's a simple pneumothorax, tension pneumothorax, and open pneumothorax.
How would you differentiate between tension pneumothorax and simple pneumothorax?
So simple pneumothorax patient might have mild shortness of breath, while the tension pneumothorax will have severe breathing difficulty, and the patient might have a tracheal shift to the opposite side, and the patient might have raised jugular venous pressure, and saturation might be fall down. But for
Okay.
simple pneumothorax, the sign and symptom will be very mild.
All right.
And most of the time, trachea is not even deviated.
Okay, very good. And there could even be signs of cardiovascular compromise and shock.
Compromise and cyanosis and shock.
Shock, very good. Okay. Can you please tell me, since this patient has already got shortness of breath and respiratory rate is 30 per minute, heart rate is also increased, how would you take care of these parameters?
Okay, so after managing the patient, if we can insert a intercostal chest tube drain, so it will also.
How would you insert the intercostal?
Okay, so upon the X-ray, then we can insert the tube on the safe triangle.
Just suppose this is the image you've asked for. What do you see and how would you correct it?
So we can see here is a plain chest radiograph anterior posterior view.
Okay.
And we can see right-sided pneumothorax with midline shift to the left side. I mean the opposite side, and
Yes.
with the axial deviation as well.
Yes.
So we have to insert a intercostal chest drain if it's readily available. If not, then we can do a needle thoracostomy.
Yes, can you tell me, according to the NICE guidelines, how would you insert it in the chest tube?
We have to prepare, drape and prep the patient.
Yes.
Then we have to insert the chest tube on the safe triangle on the 5th intercostal space at the mid axillary line.
The most important thing you are missing. Under? What?
under local anesthesia.
No, important. Ultrasound guided,
Okay.
because according to the NICE guidelines, you cannot just blindly insert it. It should be inserted under ultrasound guided. All right,
Okay.
can you please tell me, or in this case, this is one of the case, what are the other indications for central line?
Okay, so for central line, to monitor the pulmonary waist pressure, to monitor the central venous pressure in
Good.
case of hypovolemic shock or septic shock, and then to
Even during
monitor the
hemodialysis.
hemodialysis.
Yes. And when patient is undergoing transvenous cardiac pacing,
And if
etc.
the patient need TPN.
During TPN, very good. All right. Okay. Can you tell me what are the complications that you expect when a central venous
so
line is inserted?
it can be immediate and it can be late.
Very good.
So
Very good. Yes.
immediate, it can be hemothorax, pneumothorax, or
Yes.
chylothorax.
Yes.
Then maybe injury to the artery, like
Yes.
either subclavian artery. And then for late, it can be tube related. So the tube can be dislodged. I mean, the catheter can be dislodged. It can goes to the wrong direction, and then it can goes to the heart as well, and infection, sepsis,
Yes. Air embolism,
air embolism,
perforation,
thromboembolism.
perforation even can
Yes,
ultimately cardiac tamponade or arrhythmias. Okay. Right. If you have to, if the patient gets well and you have to ask the patient to get this removal of the central venous line, so what is the technique that you'll apply?
Okay, so we have to use the aseptic technique, and then it's better to do maybe under ultrasound guided, and we have to use sterile gloves, gown, and cap, face mask.
Head down
then,
to prevent air embolism.
yes, and head down to prevent air embolism.
That is the technique which is more important. Okay, what might be the indications for the removal of central line?
Okay, so if at the end of the monitoring, and if the indication is indication is over, like if we don't need to use TPN, we don't need to monitor the central venous pressure. If is
Okay.
late, or if is infected or septic.
Yes, right. Can you tell me what are the most common organism that causes central line infection?
So it can be Staphylococcus epidermidis or
Yes.
Staphylococcus aureus.
What measures can you take to prevent infection?
So we have to use the aseptic technique
Yes.
during insertion of the CV
Yes.
line.
Yes, and
So we have to prep and drape the patient. We have
yes.
to use sterile gloves, gown, face mask.
Yes.
Anything else?
Right. What should be the higher point at which you can insert the central line into interjugular vein?
Is on the lateral to the sternocleidomastoid muscle, at the midpoint of the sternocleidomastoid muscle.
Okay.
Hmm.
Wait, time went off. Between the two heads of sternocleidomastoid, or you'll dissect.
Okay, ma'am.
Let's see left side. All right. Okay. What more I can ask you? There is also a technique that needle should be directed at 30 degrees angle.
30
towards,
degree.
Yes, towards where?
From the 2 centimeter below the clavicle.
Yes.
Is middle 2/3 and lateral 1/3.
And towards the
directed
patient in what plane?
Patient will be like,
in the corner.
okay, is from internal jugular vein. It should
Yes.
be directed to the nipple.
Mhm. And patient will be in Trendelenburg position,
Trendelenburg
head
position.
down, feet up.
Mm.
Yes, all right, good. Just making sure that you know everything. And right, anything that I have missed, which should be important. And right, how in case of, all right, here you already know that patient is having shortness of breath, but how would you evaluate or assess breathing in a patient who has suffered from pneumothorax? So you
Okay, so
have done the management, now you want to observe if the breathing has been better.
okay, so we have to see the chest. Is there any abnormality in movement?
Very good.
Reduced
Okay.
chest
And
movement or not? Is asymmetry is there or not? The
And-
trachea is still shifted to the opposite side or not? We can check the percussion if it's still hyper tympanic or not, and then we can auscultate the chest.
yes,
The breathing sound is equal or not, and we
and
can check maybe
respiratory rate,
spirometry, respiratory rate, and the saturation.
saturation, right? And
Mm.
if patient is using accessory muscles for
Exercise
respiration or
muscle
not,
or not, yes.
and you can inspect the skin
You
color,
can see
nail bed,
skin color, is there any
nail
cyanosis or
beds,
not.
very good. And the rhythm of respiration.
Yes, ma'am.
Good, very good. Okay, that's about it. Good. Thank you.